Yeah, hello and welcome to the case of the month in October 2018. And as always, I'd like to thank the dental technicians, in this case, Elena Kalb, for her kind help. And would like to also mention Mr. Gianluigi Milza, who started to produce the lower jaw, and Elena finalized it. And for the upper jaw, for Miss Veronika Spirkel, who um, did the restoration for the Dean 2 or all-on-4 concept in the upper jaw with Zimmer I am pretty sure that with this case I'll show we might spark some controversy as we place immediately implants in sockets with massive apical and lateral infections and big cysts. So let's start. That's the initial situation. Patient is always the combination which we see nearly every day. Patient hasn't been to the dentist for several years, has insufficient fillings, perio problems, insufficient root canal treatments, fistulas, and so on and so on. The usual all package what you can have when you plan a big case. And if we see the x-ray, you can see the bad situation. Let's go through tooth by tooth. I think the upper right molar, we all agree, can't be saved for long term or can't be used for prosthodontics. Tooth 1-4, exactly the same. 1-3 is a safe tooth. 1-1 is questionable but could potentially be saved with a lot of work of endodontics and PR treatment. Tooth 2-2, questionable but could potentially be saved. 2-3, safe tooth. 2-4 needs to be extracted. So 1-3, 2-3, safe teeth, both canines, rest of questionable or lost. 3-6, lower left molar, I think we all can all agree, is very likely to be lost. Also tooth 3-4, and then 3-3 to 4-3, safe teeth, 4-4, 4-6, lost. And you can see at the pre-planning at the first visit, patient informed herself via the internet already, wanted to have all-on-4 in the upper jaw, and in the lower jaw, I suggested when we put her under general aesthetics that we could do the lower jaw in the same session. That means remove the teeth, clean the teeth with deep scaling, perio treatment, and place the implant and augment the cysts. And that's exactly what we did, all in one day. Preparation is always pictures, upper jaw, lower jaw setup, bite, and preparation from the technical side that we on the day perfectly prepared to treat the patient. Then general anesthesia, additionally local anesthetics to have less blood supply to the area and to be able to work more cleanly, and that we can lead the general anesthesia a little bit more shallow, that we don't have to give as much medicine to put her too deep under. Yeah, removal of the cysts in all aspects, removal of the teeth, and then you're left with such a cratery landscape. And of course, this is a jaw not ready for implants like it is now. So what we have to do, we have to smoothen the crest, and as you can see here, and then we're able to place the implants. You have to make sure that there's no soft tissue, no cysts, nothing left. It's really clean bone. And then you actually remove all the reasons for inflammation, and then there's no reason why the inflammation should stay. Then big augmentation, we used osseoguard membranes pinned to the residual host bone with titanium pins and low profile abutments on the implants to produce the screwed on bridge, and then closed the entire situation, used temporary abutments and steel wire to make sure that the impression is safe and precise. And this is then the temporary on the day. For the upper jaw, if we go back, we can be happy with our implant positions. Looks okay. And then the upper jaw denture directly on the day of treatment. Lower jaw, as you can see, big augmentations, removal of the cysts. So that all looks okay. Good. That is the situation 2 weeks later before we remove the stitches. Then 3 months later, we did the exposure of the lower jaw implants. 2 weeks later, again, we took the impression, and then again, 2 weeks later, finalized the work in the lower jaw, placed zirconium dioxide abutments on a titanium industrial prefabricated base, and then 2 zirconium bridges, vestibulary buccally veneered with feldspathic ceramic. And the front 33243, we used Emax press, that means lithium disilicate, single crowns. That's the situation. The the occlusal line does not 100% fit. I think 1-1 is a touch too long, but that we can correct, or that can be corrected in the next recall session. And the lower jaw, on the other hand, looks completely okay. That's 2 weeks after placement of the lower jaw, in the review session to check if there are any cement rests left, if the patient can brush properly, and if the bite is okay. So that's the situation. Looks all okay. Dynamic occlusion to the left, to the right, and to the front is okay as well. And the patient was very happy with that result. And more interestingly, if we have a look at the x-ray, you can see upper jaw absolutely stable with the implants, lower jaw absolutely stable with the implants, and the augmentation of the cysts looks absolutely okay and is starting to be mineralized, no inflammation, and looks like this, like a stable result. But of course, we'll take an x-ray every year to make sure that stays that way and that we can intervene at any time if something is happening. But you can see it is possible to do all in one go and still have a foreseeable result. The only thing which I personally did not like too much was the implant angulation of 3.6 and 3.5. They should have been angulated a little bit more distally, but that is exactly the difficulty when you do these implants directly after extraction, that the angulation is sometimes a little bit tricky to get perfect. Thank you very much for your kind attention, and I hope I could inspire you all with, sometimes if you really do good diagnostics, that you could potentially risk more to have the patient benefiting from less operations. Thank you very much for your kind attention, and yeah, and hope you all enjoyed a little bit. Thank you.